Good morning, everyone. Good morning. I'm Caroline Cruz, President and CEO of the Platelet Disorder Support Association. Welcome to the 19th Annual ITP Conference for patients, caregivers, healthcare providers, researchers, and regulators. This is our largest conference to date with 310 attendees. On behalf of PDSA, we're thrilled with your participation in today's historic event, our externally led patient-focused drug development meeting on immune thrombocytopenia, or ITP. Thank you to the U.S. Food and Drug Administration and to our sponsors for making this meeting possible. And a special thank you to the ITP patient community. Whether you're an ITP patient, parent of a child with ITP, or other caregiver from the US, Canada, or one of the 15 countries represented in this room, whether you're joining us in person in Washington, D.C., or participating through our live stream on our Facebook page. We are grateful that you're here to voice your perspective and share your experience on living with ITP. Throughout the day, we'll give you all an opportunity to share your opinions through our live polling. We also want to welcome the members of the International ITP Alliance. We have 18 patient advocates from 12 countries. Raise your hands, our global friends. The Platelet Disorder Support Association is dedicated to enhancing the lives of people with ITP and other platelet disorders through education, advocacy, research, and support. Patient-founded in 1998 to educate and empower those impacted by ITP and other rare bleeding disorders. PDSA is a powerful force serving and unifying the global ITP community of patients, practitioners, caregivers, advocates, and other key disease stakeholders. PDSA is committed to building awareness, educating the global community, and providing critical connections and resources that empower patients to take charge of their disease and encourage practitioners to exercise patient-centered medical care. Last month, PDSA was honored by the National Organization for Rare Disorders with the Abby S. Myers Leadership Award. PDSA was selected for this award out of more than 280 rare disease organizations representing 7,000 rare disease patients. NORD recognized PDSA for our impact in the fight against ITP, and in particular for the work that we've accomplished through our ITP Natural History Study Registry, which is made possible through a cooperative agreement between NORD and the FDA, and our research program, both of which were developed just 3 short years ago. ITP patients and their caregivers are the experts in their disease. Sometimes the greatest burdens of living with ITP may not be explicitly factored into drug development and data collection plans. The goal of this meeting is to increase awareness on the impact that ITP has on quality of life for affected individuals and families, and convey these experiences to the FDA and other drug development stakeholders. Right now, it's an exciting time for ITP. Within the past 14 months, 2 new ITP treatments were FDA approved, and there are a number of clinical trials in progress and more on the horizon. This externally led, patient-focused drug development meeting gives the ITP community an opportunity to inform the FDA about the realities of living with ITP. Patient-caregiver input aids in conducting benefit-risk assessments for products under review, helps identify areas of unmet patient needs, and helps develop tools that assess benefits of potential therapies. Your input will encourage the approval of new therapies, impact clinical trial design, inform FDA's decisions and oversight, and improve outcomes for patients living with the disease. Now I would like to introduce our first speaker. We are very honored to have Dr. Ann Farrell with us today. Dr. Farrell is the Director of the Division of Hematology Products within the Office of Oncology Products at the US FDA. She researches drug treatment development and approval with a focus on hematological disorders. Dr. Farrell.
Well, thank you very much. It's a pleasure to be here today. I think of all the programs that the FDA has embraced, the patient-focused drug development initiative is one of the best, because you actually get the patient perspective as opposed to someone coming in saying they're the expert in the disease and giving you the patient perspective. So I think this is, I really do think this is the best program, and I think we've learned a lot from having these interactions. I think as I went through my training as a hematologist, you know, I saw a lot of patients with ITP, and it was just ITP. You know, it was among the spectrum of diseases, it seemed rather a mild disease. But then when you get out into practice, you realize it actually can be a significant burden to patients, and that we have a need for new therapies. The disease has become very personal to me because my adopted father in the DC area developed ITP about 5 or 6 years ago, and he has a very refractory form of the disease, so we're always looking for new therapies for him. And so I've heard his perspective, and I understand what he goes through, but I'm actually excited to be here to understand more about other people's perspectives on the disease and listen to where you think we could move. I think in the next 5 to 6 years, we're going to have a lot of exciting new therapies in ITP that may attack the disease from a different area, and that'll be very exciting because it may help those individuals who have yet to be have their disease under good control. And I just want to thank you and tell you I'm just very happy to be here. Thank you very much.
Well, thank you, Dr. Farrell. Well, we are so fortunate at PDSA to have 13 of the top ITP experts in the world on our medical advisory board, and 9 of them are with us this weekend. Pediatric hematologist Dr. James Bussell, professor at Weill Cornell, was one of the first physicians to join our medical advisory board way back in 2000, and he is here today to present the ITP clinical overview. Dr. Bussell.
Thank you very much. This is a real honor and privilege, and I think I'm just here to be a table setter and set the stage for the rest of the day. I'm going to just try to overview ITP, and it's the thing that I find the hardest to talk about is, on the one hand, not to make it sound like, oh yeah, we solved all the problems and we know everything, because I think you know we don't. On the other hand, I don't want to sound like too depressing, like there's so much we don't know. So I'm hoping I'll be able to successfully walk that. Do you change the slides for me, or? Oh wait, I think I see it. Let me see. Great. These are my disclosures. I think it's also a privilege to have so-called conflicts of interest, in that I get to have discussions with and hear feedback on advice and join other advisors and ad boards, and I think in general that helps the field go forward, and therefore I think of that as a good thing. Just to mention briefly before talking, there's a number of manuscripts that either have come out or will come out soon that may be of interest to this audience. A group of us put together a 10-year anniversary of the thrombopoietic agents in ITP that was recently published in May. Similarly, a 20-year anniversary of rituximab in ITP was published last month. Drew Provin and David Cooter have been the leaders in the International Consensus Report, which is a kind of a medical advisor opinion report supplemented by all publications and data available. Then there are the ASH guidelines, and that's been driven by a group of people led for the second time by Cindy Neunert. And I should say that David Cooter and Cindy Neunert are here. Cindy, do you want to stand up? I know everybody knows David. I'm not sure if they know you. And then there may be new terminology and standardization forthcoming. So these are reviews that hopefully will help at least practitioners know more about the area. Now, one version of ITP, which I hope at least some of you believe in, is that ITP is a simple disease. Antiplatelet antibodies accelerate platelet destruction. In parallel with the development of the thrombopoietic agents, we've learned that those same antibodies impair platelet production. It's a diagnosis of exclusion, and in general, there's no recommendation to do much testing, and we'll come back to that. It is very, very rare to have bleeding when the platelet count is good, and good could be over 30 to 50,000. And even when the platelet count is low, serious bleeding is fortunately relatively infrequent. Quality of life is a common problem, and I don't think I need to tell that to this audience, but increasing the platelet count with treatment will often make at least parts of it, if not all of it, better. And we're fortunate in having many treatment possibilities so that even though it may require trial and error, we hopefully can find a good treatment for almost all patients. The flip side, of course, is that ITP is really not that simple and it's complicated. We don't really understand in individual patients necessarily what's driving the thrombocytopenia and how to pick the optimal treatment. We don't have a diagnostic test, and that should include for you platelet antibody testing that will say, yes, this is ITP, or no, this isn't, though there is a little bit of debate about part of that coming from Donnie Arnold in Canada and recently from Hani Samkari and David Cooter from MGH in Boston. Who bleeds and why? Who will have an intracranial hemorrhage? Those are things we're not very clear on, in that, as we said, most of the time, even with very low platelet count, serious bleeding doesn't occur, but when it does, it's devastating. We don't really understand the organic cause of reduced quality of life in ITP, although we suspect inflammation. There's hundreds and hundreds, maybe even thousands of studies of various facets of T cells. But exactly what they're doing, are there patients who are primarily have their ITP driven by T cells? All of that is unclear. And to the extent that it is clear, we can't make it clear in an individual case. Similarly, we don't know which patients at diagnosis will go on to develop chronic disease and maybe would do better if they were treated more aggressively up front when it wasn't so obvious they needed aggressive treatment. And of course, we don't really know ahead of time, with rare exceptions, and again, just as a group, not as an individual thing, who will respond to which treatment. So let's talk about terminology just briefly. I think most of you know this. I made the platelet count less than 100,000 in red because it's been changed from less than 150, which would be the lower limit of normal. And that's because of the first study by the late Roberto Stasi, who looked at many patients with counts between 100 and 150 and found that they were virtually never of any clinical significance. I suspect many of you are familiar with the terminology of duration, and the idea of this, as created by Francesco Rodighiero and a group that he put together, was to make sure we were all using the same language so studies could be compared better. And now newly diagnosed as less than 3 months, persistent 3 to 12 months, and chronic more than 12 months. It used to be chronic was more than 6 months. And some of the things that may be changed would be refractory, which at least in the original article was primarily defined as having failed splenectomy. What about diagnosis? As some of you may know, it can be a little bit tricky. Ideally, the platelet count's less than 100,000 and nothing else on the blood count, and the physical exam is normal except for signs of bruising or bleeding. That works very well in a young child who may have been completely well previously, developed a petechial rash, and could be diagnosed as ITP. Doesn't work as well in an adult who may be on many medicines, may have other medical problems and comorbidities, may be hospitalized and sick, possibly even with an infection. Given that we've already said that ITP is a diagnosis of exclusion, there is absolutely no consensus on which lab tests we need to do in which patients to further the diagnosis, and furthering it is either to exclude other diseases or to identify secondary ITP, and we're going to go over that in a minute. Important to realize is that only response to therapy, especially IVIG, is a positive diagnostic finding, in that we generally believe that if you respond to IVIG or intravenous gamma globulin, you're pretty likely to have some form of immune thrombocytopenia. But that's obviously not a lab test. So the first step, though we usually go by it so fast we don't think about it very much, is to think about things with thrombocytopenia that aren't ITP or aren't immune at all. And occasionally an inherited marrow failure state will be like that. Probably the most common mistake area is in inherited thrombocytopenias. And embarrassingly, we're not really very good at all at identifying drug-induced thrombocytopenia. There are certain drugs that can cause ITP more than others, usually seizure meds like valproate or Depakote. But if somebody is on some medications and comes in with apparent ITP, we don't have a way to say it is or isn't due to any of those medications. Testing is not very good. It could be, even if you did testing, that it's from a drug metabolite, not the drug itself. And to me, that's a black box, even though there's a nice website from Jim George's group looking at that and providing some lists of drugs. In elderly adults, myelodysplastic syndrome, or MDS, could be identified. And in a recent study that Novartis sponsored called I Wish, which was a survey of patients and physicians from 13 countries, surprisingly, liver disease or splenomegaly seemed to be a major source of confusion and delay in diagnosis. And then the next question is, okay, we're pretty confident it's ITP, meaning autoimmune thrombocytopenia or immune thrombocytopenia. How do we distinguish between primary and secondary? And this is a list that Doug Seens put together and some of us signed on for. I would like everybody to be clear that the entities are listed and are known to have ITP with them. But first of all, whether it's always immune or partly not immune isn't so clear, but especially everybody treats this like data because there is no other information on the topic that I'm aware of. But in fact, these are just estimations and may have nothing to do with reality, and in particular may vary greatly by where you as a patient live or where you're seeing the doctor, age, gender, etc. I think the best way to focus on it is to look at what I call the game changers. So if you have hypogammaglobulinemia, which in the interest of full disclosure, my wife is a world expert on, so I can pretend to be a pseudo-world expert on. If you do have low immunoglobulin levels, potentially IVIG or even rituximab would be very good. If you have a CMV infection, which may be surprisingly asymptomatic, treating the CMV with a combination of an antiviral, that's what ganciclovir is, and some form of antibody treatment can help the ITP substantially. There's a number of infections, H. pylori, which causes ulcers, even HIV, hepatitis C, hepatitis B, and there are variable effects on the ITP depending on when you eradicate or suppress the infection, depending on which one it is. H. pylori is especially confusing because in Japan and Italy, if you eradicate the H. pylori, you'll improve the ITP or eliminate it well over 50% of cases. In the US, very few cases. There's been a lot of attention to ALPS, or autoimmune lymphoproliferative syndrome, and it's been shown in studies from Children's Hospital of Philadelphia that Michelle Lambert has participated in, and also from the NIH, that this failure of autoimmune cells to die the way they should normally die can cause not just ITP, but ITP and autoimmune hemolytic anemia, the parallel disease for red cells, called Evans syndrome, and that it appears that sirolimus is uniquely effective in those patients. Lupus and antiphospholipid syndrome, another autoimmune disease or a broader autoimmune disease, probably would do well with immunosuppression, with or without rituximab, and especially are at high risk of clotting. So that's why I put warfarin or Coumadin here. And the basic principle is to treat the underlying disease and support the platelets as the reason to identify secondary ITP, and hope that successfully treating the underlying disease is possible and will improve the ITP. This is a big area for where we're not sure what tests to do. Like if somebody has ITP, how do you know what secondary causes to look for? Under pathophysiology, I'm hoping at least some of you have seen this. There's where it says antiplatelet antibodies on your left as you look at the screen, you see that the plasma, the liquid part of the blood containing antibodies from patients with ITP given to normals drops the platelet count in normals. And that first resolved the issue of, or pseudo-resolved the issue of whether ITP was a marrow disease or an autoimmune disease. Further on the right, you see studies that were originally done by Diane Nugent, but this is actually data from Bob McMillan showing that the antibodies had effects on making megakaryocytes. And while some of you might say, well, with ITP, we have lots of megakaryocytes, the cells that make platelets in the marrow, so why aren't we making lots of platelets? The answer to that is that many of them appear to be damaged and therefore not fully active. Another reason is that in some patients, I believe, and this is in the absence of hard data, that if you look here and you see thrombopoietin driving you to make megakaryocytes, it doesn't really make platelets. And in particular, the whole process of taking a megakaryocyte and releasing platelets is very complicated and incompletely understood. And therefore, if the antibodies or the immune system attack something that's crucial to that part of it, you may well be able to have many megakaryocytes and yet not be able to release the proplatelets that become platelets. This is an area where there's a lot of good work going on, but still not fully clarified. What about some of the complications of ITP? Infection is a relatively common thing. It could be from either an underlying immunodeficiency, which is increasingly being recognized, especially in complicated cases, or in ones, like I mentioned to you, CVID or common variable immunodeficiency, where your antibody levels are low, or has been very commonly reported to be a secondary effect of treatments, especially steroids, but other immunosuppressives as well. Thrombosis has been increasingly studied in the past, say, 10 years, And I think the important thing here is we don't fully understand all the reasons for it. Antiphospholipid antibody is one. We believe that as platelets are destroyed, they release microparticles or little bits of their membrane, and this may also contribute, but there may be other reasons as well. And Lamia Garabet and Walid Ghanima in Norway have done some nice studies on this. Important thing for everyone to know, low platelets do not guarantee that you won't develop a clot you shouldn't develop. And that's why if there's a question of clotting or if there is a clot, it's important to treat the platelets and anticoagulate the way you would somebody who doesn't have ITP, as opposed to just saying, well, the platelets are low, we'll be fine. Finally, we talked about reduced quality of life, and this still isn't well understood. I think the first paper on this was in 2008, spearheaded by Bob McMillan. And the key factors here, and you probably know them better than I do, is that there are a whole number of factors. Some of them are different in different people. And the thing that we don't understand is that there seems to be an organic disease-driven process that isn't so clear, but some people are really plagued with depression and low energy, and this is something we would like to be doing better about. And I think it's probably the largest, Dr. Farrell mentioned the burden of ITP. I think that's a very important part of the burden, and it's certainly not entirely treatment related. Moving on to treatment, I'm going to talk only briefly about first-line treatment. One of the things, and this is something that Dr. Neunert has been particularly active in the pediatric patients, and what are the reasons to start treatment? Many of you, I'm sure, know that children may get better on their own, certainly in well over 50% of cases. So if you don't need to treat them to prevent bleeding, then it's great if you don't treat them. And I'm not going to talk about this further, but it's also something that is now a consideration to some extent in adults. We also know that if you have bleeding, the more bleeding you have, the more bleeding you will have. And that's an issue. In adults, generally a platelet count less than 30,000 is used as an indication to treat, but you could argue about maybe that should only be a consideration in older adults. All these things are largely data-free, so it's hard to know. Obviously, lifestyle is very important. Sports and a job with trauma, maybe a construction job, are somewhat obvious, but I put travel up because it may put you as a patient traveling out of touch with your usual medical care system in case you have an emergency. There's also the issues of if you're somebody, especially who's a nosebleeder, what happens on an airline if you're starting to have a nosebleed and can't readily stop it. Comorbidities have been shown to be very important, and that's why the intracranial hemorrhage rate in adults appears to be higher in more elderly adults who have more diseases, more medicines, and may even be on antiplatelet agents. And finally, reasons to start treatment include the quality of life ones listed on the bottom, including appropriate anxiety concerning the risk of bleeding, or fatigue, depression, etc. So what are the frontline treatments? These are the things that bring up your count ideally quickly and are a short-term thing. The disadvantage of them is they're not thought to be at all curative. In children, if you need treatment and the child's going to get better anyway, then it potentially makes sense. In adults, a little less clear. So IVIG is the fastest way to increase the platelet count. It does require a number of hours to infuse, and there are certainly infusion reactions in ITP, especially headache, but maybe also fluid overload. Earlier versions had problems leading to kidney damage, to hemolysis, and to thrombosis. And the FDA has had a role in reducing hemolysis by asking for a lowering of an antibody level to blood group A, and in thrombosis by identifying that some preparations had factor 11A. Doesn't really matter very much, but it promoted coagulation, and removing that has reduced all these risks, we believe, substantially. Anti-D immunoglobulin is not used very often, but Mike Tarantino, who's also here, showed that with 75 mics per kilo, it brings up the platelets as fast as IVIG, provided the patient is Rh positive. That's about 85% in the US, doesn't have antibody on their red cells, hasn't had their spleen removed, and we wouldn't want to give it to somebody who's already anemic. There's a slightly less than 1 in 1,000 risk of a major bleeding event where you break down an excessive number of red cells, get very anemic, and may have even a very serious reaction. And Ann Gaines from the FDA reported several deaths from this in 2000 and 2005. Finally, there are common reactions which occur, fever, chills, nausea, vomiting, headache, that appear to be prevented by a single high-dose steroid pre-medication, but you do expect a minor hemoglobin decrease. Steroids, there's many different types to use. There's debate about should you use 4 days of high-dose dexamethasone. That's been gaining in popularity, not because it's been shown to be curative the way people hoped, because randomized trials have not substantiated that, but it appears to have less side effects, sort of 4 awful days, but it ends after day 5, as opposed to bad days for more than a month. Importantly, the ASH guidelines are strong on suggesting that you should limit prednisone use to 6 weeks, and ideally not resume it if you do that and then the platelets fall again. Of interest, there's still a lot of steroid use in the United States, and ideally that would be reduced. What about second-line treatment? And I'll need to finish in the next few minutes. If you have a typical case where maybe there's a 36-year-old woman, she has fatigue, heavy periods, and has a rash that's petechiae and bruising, tired, needs a lot of sleep, has petechiae, bruises, blood blisters in her mouth, blood count or hemoglobin's a little bit low, and the MCV is low, which helps you to think that it's low iron, and her platelets are low. Because of the blood blisters, she receives gamma globulin and prednisone. Platelets go up nicely to 87. That says she has ITP. But when she tapers the prednisone, the platelets fall. So here, in a lot of cases, I think practitioners would restart prednisone, and that's an area where we hope they would go to second-line treatment, even if the diagnosis was only 6 or 8 weeks before, so that you would still be newly diagnosed. So what second-line treatment would you think about? And I'm going to go through this briefly. There's a number of candidates. I call immunosuppressives the least exciting kid on the block, since they're the least effective probably, but they've been around for a long time and they do have effect and are widely used in certain countries. Rituximab I use with dexamethasone. I call it polarizing because some people like it a lot and others don't. It's always been thought in the US to be overused because the doctors who were taking care of patients with ITP are also treating lymphoma, and they're very familiar with giving it. Splenectomy's been around since 1916. Thrombopoietic agents have made a major impact, and mentioned the licensing of new treatments. One is avatrombopag, and one is, which is a TPO agent. The other is fostamatinib, which I guess I shouldn't anymore call the newest kid on the block. I'm not going to talk about FcRn inhibitors and BTK inhibitors, but these are both very exciting, have good results, and are entering the realm or in the realm of phase 3 trials, so they may become available soon. and I'm not sure about U.S. versus ex-U.S. So how do you decide who to treat? Just for the record, if somebody had leukemia, you would do a big workup, chromosomes, flow cytometry, staining of cells. You would divide the leukemia into one of 10 to 20 categories, and then you would come up with a treatment that would be planned for the following years, including monitoring for toxicity, follow-up off treatment, when to do bone marrows, et cetera. I think we all know that that's not the case in ITP, so there is no specific answer that you have to use. I think it's important to include you, the patient community, and you, the individual patient, in the discussion. And this is a list of some of the many factors. And while this slide is borrowed from Roberto Stasi, the person I credit it to in my thinking about it is Rachel Grace, who is the head of the Pediatric Icon Group in North America. So what do you want to use? You want to cure? Splenectomy. You want to cure, but you don't want splenectomy, or you had it and failed it? Probably something with rituximab. If you want the highest likelihood of a good count, probably a TPO receptor agonist. I'm just going to show you single data slides. This is a bias that I have that's not widely agreed upon, but there's at least 4 studies published that support this from different time periods and different groups, and that is that women of childbearing age, as you see in that top line, do the best with rituximab, in our case with dexamethasone, but even without dexamethasone. So we believe that somebody like the patient in this case would benefit from it. A lot of side effects, but mostly they're either preventable, like first infusion reactions by giving steroids, or occur very rarely. What about splenectomy? Well, you can see here that the rate of splenectomy is going down to 2009, and if anything, it's continued to fall. There's 2 sets of publications in 2018, one from Donnie Arnold, Keith McRae, and Chakravarty, and their basic message is down but not out. And I totally agree. If we've tried to do a medical decision analysis that we're still trying to finalize, but all these treatments come out about the same. And here you see that long-term response from a single center in Italy is very good, something like 60, 65%. More recently, we've become aware, as you see in the left part of the slide, that there are thromboembolic events, and Roholt et al. From the Danish registry have shown that there's about a 1.5-fold increase of stroke long-term, and there may be more clotting after splenectomy if you have to use other treatments. So, complicated situation. Thing that's often forgotten about in splenectomy cases is the intracellular parasites. If somebody either has or will be exposed to malaria, babesia, dengue, and I left off Ehrlichia and anaplasma, you're much harder to treat if you don't have a spleen. So these are issues to consider, but not issues to stop you from treatment. And thus far, unlike when you take the spleen out for somebody with red cell breakdown, no pulmonary hypertension has been identified. These are the TPO agents. The bottom one, lucitrombopag, has only been licensed thus far, and I don't believe for liver procedures, and I don't believe they're doing a trial in ITP, though they may. The SSS bioagent is a Chinese agent that has to be given subcutaneously daily, and that's been licensed in China for, I think, longer than romoplastin and L-trombopag have been licensed in the US. Maybe in Eastern Europe a little, but I think likely that will slowly disappear over time, though I could be wrong. Avatrombopag is the newest agent. It binds the way L-trombopag does, but it's not a chelator, and therefore does not have dietary restrictions, which is an advantage. Like L-trombopag, it's given once daily. L-trombopag has to be given on an empty stomach and away from dairy. Romoplastin is given subcutaneously once weekly. And Dr. Farrell, I don't mean to give you a hard time for being here, but I remain confused about why we can't teach patients to give Romoplastin at home. This is, no, please. I was stepping out of bounds. I don't think I should be applauded for that. With L-Trombopag, you can see it's a small molecule. Romoplastin is 4 peptides hooked to the back half of an IgG molecule. Because it's small and has the Fc receptor, both of those are expected to have an effect in pregnancy. And while there's been one study in pregnancy thus far, neither of these agents nor avatrombopag have been used enough in pregnancy to really know whether they're safe and effective. The SSS bioagent was safe and effective in a study of 31 people in China and had no ill effects on the kids. AMG 531 and TPO bind on the outside of the receptor. You see where that red circle hits, and then they signal for more platelet production. L-Trombopag and AKR 501 as avatrombopag seem to bind around the transmembrane domain. And there have been some very nice studies from Britta Will at Albert Einstein in New York, Alessandro Baldwini between Tufts in Boston and Pavia in Italy, showing that they signal differently, which may be why sometimes if you use one and the patient doesn't respond, they will respond to the other. Way back, we used to think these agents were inert. Caroline, do I have 5 more minutes?
Yeah, I was actually just texting to find out how many more slides you have.
Okay, but 5 minutes is okay? 5 minutes is good. Okay, sorry. This is just showing that they have an immunologic effect. It's hard to see in this slide, but the idea is these are not inert agents and may help reboot the regulatory system. And John Semple, who's here, has done some very interesting studies in animal models about how they might work. This is showing one of the TPO agents improving quality of life. You see that the green bars are going up and the red bars are not doing much or going down. That's the placebo. Side effects, biggest one in my mind is too much clotting, thrombosis seen with both of them. L-Trombopag has to be monitored for abnormal liver tests. In kids, making antibodies to Romoplastin seems like it's an issue with longer-term use, at least in several % of kids. And our concerns about scarring in the marrow, increased marrow reticulin, seem to not be a clinical problem hardly ever. Tons of studies. The orange ones are the largest randomized placebo-controlled trials in ITP, and the bottom 2 on each side are long-term use studies out to 6 or more years with each of these agents. You can maintain the platelet count, as you can see, for a fairly long time, and the dose will be fairly stable. You can see here that the dose is on the high side for Romoplastin. It's 6 mics per kilo. A lot of people don't want to go over that for no reason. Sometimes, back to the immunologic effects of these agents, you can actually successfully discontinue these agents. You see here with L-Trombopag. And here you can see with Romoplastin that if you start treatment early, in this study from Adrian Newland's group and Drew Proven, you can get about 1/3 of the patients coming off treatment, and these were not always started until about 6 months from diagnosis. So I think back to the let's not use too much steroids idea, instituting this or other treatments earlier may allow you to discontinue treatment better. So in the wrapping up phase, if you use a TPO agent, take you maybe a week to get the count up. Rate of response varies depending on your definition, meaning do you want a very stable response greater than 50,000 all the time? That's probably 40–50%, at least from studies. If you're willing to settle for several counts that are good, more like 80%. We talked about switching. We talked a little about cure. Because of their unique mechanism of effect, if you combine them with other agents, they often work really well. And I see the biggest mistakes as changing doses too frequently. That includes holding the dose when the count gets high. You should just reduce it a little and give it. And with L-Trombopag, not adhering to the dietary restrictions. So we went over all these agents. I'm sure a lot of you have used some of them, and not clear yet what the newer agents will do. An advantage of fostamatinib is that it seems to not only not lead to clotting, but protect against clotting. But where it should be used remains an open question. Talked about a lot of these different areas. And what are some of the major issues? Caroline, this is the last slide. You don't have to text to find out. Some of the major issues are we need molecular markers or other biomarkers both to confirm the diagnosis and to guide treatment, and for that matter, to guide prognosis, i.e., will this be a patient like some of you, I'm sure, who have had this, quote, forever and feel like it'll continue forever or not? There's many studies of groups of patients, but relatively little of that data is transferable to the care of individual patients, meaning if you do a test, does that tell you, an individual patient? It might say you have a 70% chance or a 30% chance, but it doesn't tell you what's going to happen with you. And probably one of our best sources of information in a given patient is to try something and see what happens. And that means there's an unfortunate amount of trial and error. Now, I don't want to finish on a down note, so I would tell you that if there was easy answers to these questions, we would have probably had them already. And for example, Jenny Despodovic is doing some remarkably good work on genetic diagnosis and prognosis with ITP, and she's very close to having an index in children for which children at presentation will have their ITP get better and which won't. So maybe we'll have that for adults too, and I'm sure we'll learn a whole lot more in the next few years. So thank you very much for your attention.
I didn't want you to think I wasn't paying attention when you looked down and saw me texting, so I just wanted to let you know. I wanted you to know I was actually working. Thank you, Dr. Bussell. Well, as you just heard, many things have changed in the world of ITP over the years, especially since I was diagnosed in April of 2000. It was 2 o'clock in the morning when I got the call that would change my life. The person on the other end said, "Mrs. Cruz, this is Dr. Jones. You need to get to the emergency room immediately. Don't brush your teeth, don't shave your legs, don't take a shower, don't bump your head. You have a platelet count of 2,000. You could bleed to death." And that was the beginning of my struggle with ITP, bone marrow biopsy, numerous hospitalizations, the debilitating fatigue, 7 months of 60 milligrams of prednisone daily. As you can see, I'll do anything for PDSA and the ITP patient community, even digging up these old photos. The reaction to danazol landed me in the emergency room again, an unsuccessful splenectomy that left me extremely ill for 3 months, and of course at higher risk for infections, thrombosis, and cardiovascular problems. I remember one of the first things that I asked my hematologist was, can I die from ITP? And he said the chances were very low, less than 1%. However, he added that I had a greater risk of dying from the side effects of the treatments, and that always stayed with me. And as you will hear from so many others in this room, having ITP has a huge impact on a person's and a family's quality of life. It was an extremely stressful time in my life, filled with anxiety and depression, but I'm one of the lucky ones who found my own path to healing, and my ITP has been in remission for 15 years. And that is thanks to PDSA founder Joan Young. It was hearing her story at my first PDSA conference that gave me hope and inspired me to keep searching for answers. And that's why I invited Joan here today to share her story with all of you. Joan?
Thank you, Caroline. It's really a joy to be here. On August 29th, 1992, I was diagnosed with ITP. My life was changed forever. I had noticed some bruises weeks before and was much more tired than normal. I thought it would all go away. So I continued traveling and working at my IT job at a Fortune 500 company. I was 46. A single mom with almost grown daughters, a house, a mortgage. It was a struggle. And when I came out of denial and saw some doctors, it took about 2 weeks and various blood tests for them to tell me I had ITP. My platelet count was 7,000. I was immediately put on 60 milligrams of prednisone and told my platelets would go up. The prednisone didn't raise my platelets very much, but it did make my blood pressure rise, my emotions seem out of control, gave me a mouth fungus, and kept me up most of the night. I went on short-term disability at my job. I couldn't possibly concentrate or act sanely in my condition. We began to taper the prednisone, which caused my body to go into another tailspin. Since prednisone was not working, my hematologist began bullying me to have a splenectomy. A splenectomy would leave me permanently immune compromised with no guarantee that it would help my ITP. Plus, I was already missing my thyroid, my tonsils, and my adenoids. We tried IVIG instead. And one morning after I came home from the hospital, after my first series of IVIG treatments, still on some prednisone, I collapsed and lost consciousness. The emergency squad took me to the hospital where I was diagnosed with a seizure and had a resting pulse of 120. Now, in addition to the prednisone, I was taking heart and seizure medication. With the new meds, my resting pulse was still erratic, and it felt like part of my brain went away. When my platelets dropped again, my new hematologist tried several more rounds of IVIG, each one less effective than the last, and each one giving me chest pains and prompting more trips to the hospital, more tests, and more calls to my doctors. After all this, my platelets were back to below 10,000. We tried colchicine and another round of IVIG. They had no effect. On November 11th, 1992, when I went to my hematologist for my twice-weekly visit, I had an official platelet count of 0. Reluctantly, I agreed to a splenectomy. So with a platelet count of 2,000 and pumped up on a large dose of prednisone, I had my spleen removed. The surgeon created a graceful cut from my mid-belly to my left hip and removed the organ. My platelets did rise to almost 100,000, but quickly fell. By December 14th, before my scar healed, my platelets were back to 5,000. We then tried danazol, which barely budged my platelets, but did give me the beginnings of a beard. What? My Christmas shopping consisted of paging through catalogs and making phone calls. For months, I was obsessed with my bruises. Were there more? Were they healing? Were there more blood blisters in my mouth than the day before? Where else was I bleeding that I couldn't see? Would I live long enough to see my grandchildren? My granddaughter, by the way, is at the photo booth. I had a cardiologist, a neurologist, and an endocrinologist, in addition to my hematologist, a primary doctor and a psychologist, all requiring appointments and tests. As a result of the treatments, I was prescribed medications for thrush, anxiety, low iron, heartburn, stomach acid, chest pains, plus the heart and seizure meds. I could barely manage my life. I didn't recognize the person I had become. Except for a few weeks after the splenectomy, my platelets hovered below 10,000. It was February, and I was now sick with the flu. My platelets were falling. We were desperate. My hematologist suggested a dose of vincristine plus 6 prosorbicolum treatments. We were at the bottom of the treatment list. I was warned that I might lose my hair from the vincristine, plus the hospital and my doctors had no experience with the prosorbicolum. I was hospitalized for 2 weeks for this combo. The nurse, wearing what looked like a hazmat suit, gave me the dose of vincristine, a push through the IV in my lower arm. The Prosorba treatments required huge needles in both arms so my blood could go out from one arm into the centrifuge, pass through the column, and back into the other arm. About 10 days after the vincristine shot, my hair began to fall out in clumps. During the 5th Prosorba column treatment, I passed out and had one of those white light experiences. The people in the blood donor room panicked, trying to find the drugs that would bring me back. After all this, my platelets went up to a high of 38,000, but I was left a shell of the person I had once been. I was so weak I could barely walk upstairs. I was bald except for a few strands of gray hair. I envied people who had hair, who could work, who had a life. I decided to take my chance with the disease. The treatments were killing me. How I got from this low point in my life to 26 years of a normal platelet count is a story for another time. Although my platelets are no longer a problem, I have remnants from the treatments. I am immune compromised and more prone to blood clots from the splenectomy. My IQ is diminished from the seizure meds, and my veins are distended from the Prosorba needles. Every time I see a bruise, it brings back the traumas. On the positive side, I was able to go back to work, ski and dance again, and treasure my 4 grandchildren. In 1998, I founded the Platelet Disorder Support Association to help others avoid the tough times I experienced with the disease. Since then, PDSA has assisted thousands of people worldwide. There is an incredible need. I'm glad the FDA is listening.
Thank you, Joan. Well, we all know that numbers tell a story. Every day we hear from ITP patients who recount their personal journey with this bleeding disorder, reciting from memory countless treatments, hospitalizations, blood draws, platelet counts, doctors, specialists, and procedures. And while every patient's experience is unique, the stories of the physical and emotional roller coaster that living with ITP presents is very much the same. This is why the PDSA exists, to offer life-changing support and information to ITP patients. So thank you, Joan, for creating the PDSA. But there is still so much work to be done to address the burden of disease and ensure patients are educated and feel supported. So now we will transition to the portion of the meeting where we want to hear from all of you, the patients and families who live day in and day out with ITP. We've heard a clinician's view of the disease along with 2 former patient experiences, but today is a rare opportunity to gather information in a systematic way on your experiences with ITP, assess currently available treatment options, and record patient preference regarding the development of future therapies. As you heard from Dr. Farrell, your input can help inform the agency's understanding of ITP to assist with drug development and review. So I want to spend a few minutes here explaining how the rest of today's program will go and the different ways we will be engaging with all of you in the room, as well as those patients and caregivers who are following along on our live webcast on our Facebook page, in order so that we can hear everyone's voice as part of this conversation. So the program will be broken out into 2 topics. The morning session will address the health effects and daily impact of ITP. And then after lunch, the afternoon session will address current approaches to treatments. For each of these topics, we will kick off the session with a panel of patients and caregivers with a range of experiences who will share their personal stories living with ITP. The goal of the panel discussion is to establish context for a broader discussion where we will ask all of you, those in the audience, to share your experiences, thoughts, and feelings on these topics. And then following the panelist stories, we will have another set of polling questions, which you have received instructions for on how to download the app on your table. I guess if you're having an issue, you can raise your hand, and we have some folks in the room who might be able to help you. And then, of course, we have a description on our Facebook page for the live stream. The polling questions are for patients or their caregiver, or a caregiver on behalf of the patient. So we only want one individual from each family responding to the polling questions. Please know that your responses will be anonymous, and they'll be pooled with others who respond similarly to you. This data is important in creating the full picture of what the ITP patient community looks like, and will be used in our official report to the FDA, as well as be available on the PDSA website. After the polling questions, we will move to a facilitated discussion with all of the patients and family members. I will ask questions, and if you would like to provide your input, please raise your hand, and we will come to you with the microphone so that everyone can hear what you have to say. I will first ask that you state your name, and if you are a patient or caregiver, how long you've been living with or dealing with ITP. And if we are unable to get to everyone over the course of the day, we encourage you to provide written comments, which will supplement what we collect today and be part of our Voice of the Patient report. As I mentioned, that will actually be on the PDSA website and the FDA website in the coming months. So for this meeting to be successful, I encourage all patients and caregivers to share their experiences and perspectives today, because the folks from FDA are here to listen to you. So let's make sure we take advantage of this really unique opportunity to let them know what it is really like to live with ITP. So don't hold back, don't be shy. Not is now the time to do that. And please share any and all experiences on your journey with ITP. So before we hear from our first set of patients and caregivers, we have some basic demographic polling questions for all our patients or caregivers on behalf of patients who are unable to respond. So everybody ready? Our first polling question is to see who we have in the room and online. And again, only for patients or their caregivers. Please answer the question as soon as possible so that we can then move on to the following question. Once we move on to the next question, you will not be able to answer the prior question. So question number 1, I am an adult with ITP, a teen, parent, guardian. Let's see. Again, if anybody's having an issue, just raise your hand. We have a few folks in the room, Alex and Nancy, who can help you. Is it working for everybody else? Does it seem to be working? Barb, is it working? Okay. Great. So it looks like the majority of people are adults with ITP. We have some teens and of course, some parents of children with ITP. All right, moving on to the next question. Where do you currently live? As expected, most folks are here in the US. Next question, are you aware of any family history of low platelets? So around, let's see, it's moving up. 14% of you are aware of a family history of low platelets. But of course, the majority of us, there's been no family history of low platelets. What is the patient's, we'll move on to the next question, what is the patient's sex? Well, a clear majority are female, or the males just don't want to answer. All right, moving on. What was the patient's age at confirmed diagnosis? So how old were you when you were diagnosed, when you were officially diagnosed with your ITP? I know I didn't feel well for 3 years before I was officially diagnosed. So 41 to 60 years, majority, 2 to 12, close, oh, a tie, 2 to 12, and 41 to 60 years. All right, we'll move on to the next question. Select the patient's age at confirmed diagnosis. Didn't we just do that one? Yeah, we did. We just. Select the number of years that you have been living with ITP. How many years have you been living with ITP? Well, it looks like the majority is 1 to 3 or 4 to 9, but we have a few people who've been living with it for 50 plus years and 60 plus years, living with ITP. All right, moving on to the next question. What health insurance do you have? So the majority of people, of course, have private insurance. Oh, okay, so we're going to ask the first question again because some people were having problems getting into the live polling. So the first question was, I am, are you able to put that slide back up at all? There you go. I'm an adult with ITP, teen, parent, guardian. Okay, I think we're about set there. Well, thank you to everyone here in the room and online for participating in the first set of polling questions. We will ask you to answer additional polling questions after our panel presentation on each topic. And with that, we are going to invite our first set of panelists to come up to the stage so that we can discuss topic 1, living with ITP. We will have the panelists share their experiences living with ITP, so you guys can come on up. Followed by more polling questions so that those in the room and those listening live on Facebook can share their experiences of living with ITP, and then we will ask those of you in the audience to share your experiences. We will explore the symptoms that you experience from ITP and which ones have the most significant impact on your daily lives. John, I'll have you here first. Yep.
We tried.
That's all right. We want to know if there are specific activities that are important to you that you can't do or fully, how those symptoms have changed over time. Do you feel that your condition is being well managed, and what worries you most about living with ITP? Before we have our patient panelists introduce themselves and share their stories, I would like to share our gratitude with our panelists today. We realize it takes a tremendous amount of courage to share these personal stories, so thank you to all of you here today. So we have John, Leilani, Barbara, and John. And then when John is finished, we have a video that we wanted to share with you that we filmed back in April with the DeRamo family. So with that, John, I'll turn it over to you.
Good morning. My name is John Colgan, and I'm here today to tell you a little bit about how ITP has impacted my life. In 1982, I had joined the Marine Corps, and while in basic training, we did what they call the confidence course. And after a couple of days of that, I had bruises all over my arms and legs and midsection. It was so bad that a sergeant actually asked me if somebody had been beating on me. When I answered no, I went and saw the corpsman, the doctor, and a week later, I got an honorable discharge out of the Marine Corps because they felt that I had joined the Marine Corps to get medical attention because I came from such a small town in Alaska, a place called Skagway. It had about 500 people in it. So I went back home, and maybe a week or so later, I got a nosebleed. And it bled, and it bled. Well, again, small town, no doctor, went to see the nurse, and she packed my left nostril. And 2 hours later, it bled through the packing. So she said she didn't know what was up, but I had to go somewhere and get it treated quickly. So I went to Juneau, Alaska, the capital, but that was an 8-hour boat ride. Luckily, by the time I got there, my nose stopped bleeding, so I didn't have to have it cauterized. But after seeing a hematologist, having blood tests, that's when I found out that I had ITP, and my platelets were at 0. So I needed to be treated, but there was nobody in 1982 in the whole state of Alaska that could treat me. So I got on another ship, and I took a 3-day boat ride, this time down to Seattle, Washington. Met with a hematologist. He says that this is going to take a little bit of a procedure to get me to where they can do anything for me. So my mom had to get me an apartment and had me fill out all my paperwork so I could be emancipated, so I could make my own medical decisions, because she had to go back to Alaska with the family and her business. So over the next 12 weeks, I gave 10 units of my own blood, had the bone marrow biopsy, did a blood time test. I don't know if anybody else has ever had one of those. They take a plunger and they put it on your arm and poke 2 big holes in it and just sop up the blood as it comes out, waiting for your body to clot. Mine never did, so they had to put butterflies on it. I found my own surgeon, and I had my spleen removed. And remember, this was all at 17 years old and all by myself. A little scary, but it seemed to work. Well, until 2010. In 2010, it came back, and this time it came back with a vengeance. By that time, I had been married for 15 years. I had 4 children, and I had working at a place called Costco for 13 years. And one morning I woke up and I had petechiae on my arms and my legs and the blood blisters in the mouth. And I went and saw my primary, and he's like, yeah, your platelets are only at 3,000, and we need to see a hematologist. So this was my first hematologist as an adult. And the first thing he did, in 2010 was put the scare in me. He said, John, with your platelets, at 3,000, if you hit your head, you could have, brain bleed and die. If you get in an accident in a car, even the seatbelt, could give you bleeding in the chest and you could die. Or I could cut myself at home and bleed out before anybody came there and die. That was his thing, was to scare me, I guess. I don't know. And he put me on steroids right away. And over the next few years, we always tried steroids, but we tried Implate and rituximab and IVIG and a couple other things. And I don't know about everybody else, but not only does the steroids give you that moon face, but it also made me very angry. So by 2014, 4 years into this, I got a divorce. I'm not saying it was all due to ITP and the steroids, but that definitely, I was going to the doctors twice a week for a long time, and so it added to it. So shortly after that, Costco put me on short-term disability because my work was, not up to par, because I just had no energy. And that short-term disability turned into long-term disability that turned into full-on disability. And I was getting more and more depressed. And then my doctor tried vincristine. I did 6 rounds of vincristine. And I know Joan said she had it. That stuff is terrible. That stuff, you think you're going to die. I mean, just to take a shower you had to take a nap after taking a shower after getting up, and you have no energy. It gave me neuropathy in my feet and in my hands, and I got so depressed that for 10 months I didn't leave my house. I was afraid that I was going to die, and the depression and just not feeling well at all. So in 2015 I tried to commit suicide, and luckily it didn't work. And I was going to intensive outpatient therapy classes, and I met my wife, Rebecca, luckily, and she changed my life. She showed me that there was a reason to live again, and that, maybe I didn't have to do things as I used to do, but I could still be alive. I didn't have to be a bubble. So one of the things that, I'd like to say is, first of all, what it's done to my body. I've done steroids from 2010 till August of last year. So I've had cataract surgery in both of my eyes. I'm a type 2 insulin-dependent diabetic. I have terrible skin from, when I was on the steroids, 80, 100 milligrams, you could just push my skin and it would put holes in my skin. I wear the insulin pump now. But what I tell all the other warriors out there, especially the young ones, is don't hide from this. You don't have to, live in a bubble. You're allowed to go do things. Just instead of riding a motorcycle and going over jumps, ride a regular bicycle and put a helmet and pads on. You don't have to play, full-on football and tackle football. Play flag football or touch football. I mean, you can still do things. You just have to remember that you're a little bit different and to do things a little bit differently. And to the medical community, I would like to let people know that, again, this is not just your blood. It is not, it affects everything, your mental, your emotions, your energy level. I'm on anxiety medicine, I'm on depression medicine, and then the diabetes and all that other, stuff that's come with it. But it's a whole body thing. One day, like they were saying, the genetic marker, I would like to see a gene, something to do with your genes where they can just kind of go in and fix me, But I've done so many things and they don't know what it is. Or a test that I could actually do and say, hey, today my platelets are 20. Hey, I'm doing great. Oh, they're only 6, So thank you for listening.
Morning. My name is Leilani, and I am a caregiver. This is my story as a parent perspective. We first noticed that something might be wrong with Joey when he was 2 years old. His body was covered in bruises, way too many to count. We expressed our concerns during Joey's 2-year checkup at his pediatrician ordered lab work. I will never forget the moment when my whole world changed. I had just put Joey to bed. I had just put Joey to bed when the phone rang. It was just after 10 o'clock at night, and I had a feeling that this was not going to be good. It was a phone call that no parent ever wants to receive. On the other end, a doctor told us that Joey's platelet count was 18,000 and told us to come straight to the emergency room. Your son could be bleeding internally. He said, I hung up the phone as tears streamed down my face. I rushed over to my son's crib, picked him up and hugged him tightly, and immediately we rushed to the emergency room. After several more tests, Joey was diagnosed with immune thrombocytopenia. He spent the rest of the year in and out of the hospital trying to bring his platelet count to safe levels. We were handed the diagnosis of a rare disease, had few answers, and began to worry. We had so many questions about Joey's future. Will Joey have a future, or can he bleed to death? Will he be able to live and play freely like other children? Will he be happy? Overwhelmed and helpless, we couldn't help but feel that we were somehow letting Joey down. As parents, we try to protect our children from the dangers in the world, but how were we to protect Joey from something we had never even heard of? Fast forward 2 years, I was determined to do whatever needed to ensure that Joey's quality of life would not be greatly affected by his illness. When the time came for his diagnosis to go from acute to chronic, I refused to accept that this was his reality. I used denial as a coping mechanism to avoid the heartache I was feeling. So many late nights searching the internet about children with ITP and how childhood ITP usually resolves itself within 12 months gave me a false sense of hope, because with each visit to the lab and praying for higher platelet counts, our hopes were dashed once we found out his platelet count was still low. There's no other way to describe it other than being on an emotional roller coaster. I was feeling lost and helpless and trying to keep a brave face for Joey. The day the hematologist told me that my son's condition was now considered chronic and that there was no cure, I thought about what I could do and what was in my control, and I remembered all the times Joey spent in and out of the hospital. I recalled the child life specialists that interacted with him and worked closely with him to make his experience at the hospital as positive as possible. I thought about my role as my son's caregiver and what I could do that would ease his suffering, or at least make it bearable. I just wanted to make it go away. I wanted my child to be normal and healthy, but worried how this illness would affect him emotionally. To help him cope, I looked into child psychology or therapy. I wanted to prepare for when he was old enough to communicate his feelings. I was just not sure how I would go about helping him. I decided to pursue a counseling degree. I knew that my son would one day need someone to help him through his struggle, and I wanted to be there for him. I wanted to learn about the counseling profession so that I can help him navigate his feelings, because he was too young to fully comprehend all that was happening to him. My desire to help Joey with the challenges he was facing forced me to evaluate my strengths and my weaknesses. Also, living with a child diagnosed with a chronic medical condition can have a profound impact on the entire family, not just the child. As a caregiver, I had stressors that I needed to manage and coping strategies that I needed to learn. I recognized that how I dealt with my son's diagnosis might not be the same as another parent dealing with a child with a chronic illness. 8 years after the shocking diagnosis, Joey continues to struggle with ITP, and so do we. He has endured a myriad of tests and doctor's appointments. His biggest challenge has been being able to play like a normal kid. When Joey was diagnosed, he was restricted to light play. These restrictions have guided his way of life since then. Joey has been advised by his doctor that he will need to reevaluate the sports that he participates in, because it gets more dangerous for him since he knows when his platelet count is low. We often find ourselves obsessing over Joey's platelet count. It's always on our minds, always. Every year, we must educate his teachers and coaches about ITP and the importance of contacting us immediately if he is seriously injured. Joey feels embarrassed and has not shared with his friends his medical condition. He refuses to wear his medical ID bracelet. We get it. It's hard being different from everyone else. So you can imagine how hard it must be for him to navigate 4th grade, living with a chronic condition without the support of his friends. His platelet count remains low, and he constantly questions why he has ITP. Maybe one day he will share his condition with his closest friends. When people see Joey, they don't know his daily struggles, because he appears to be a healthy 10-year-old boy who tries to live a normal life. He does well in school and is part of many activities such as acting, dance, and his elementary school's leadership academy, and he participates in baseball, basketball, and soccer when his platelet count is at safe levels. Joey feels that the only solution to ITP is to find a cure, and his dad and I share in his hope for people with ITP. Thank you for listening to my story.
Good afternoon. I am Barbara Pruitt, and I live with chronic refractory ITP. I was diagnosed when I was 4 years old. I was treated with cortisone, and at the age of 7, I had a splenectomy. I went into remission for 3 months. That is the only remission I have experienced in my lifetime. It left me with an 8-inch scar on my abdomen and a compromised immune system. When I was 19, I was given another drug that did not work for my ITP. It did, however, cause me to have ovarian failure. So at the age of 28, I was in menopause. That didn't keep me from looking for a treatment, though. 10 plus years ago, I was in a clinical trial for the new TPO agents, and although they didn't work for me, they gave me kidney damage. It took me 1.5 years before I felt like myself again. I could barely get out of bed and down the stairs for months. Since 1961, when I was diagnosed, I have tried every drug and treatment available, and none of them have worked for me. My platelet count has been in the single digits for the last 25 years. Let's face it, ITP sucks. It's not that we just live with low platelets. It invades every aspect of our life. The 4 things that bother me the most about ITP are fear, guilt, fatigue, and depression. The fear. You wake up with fear every day. The fear cannot evade you, and for good reason. You wonder, am I going to die today? Will I have an accident? What if I have to go to the hospital? Will the ER doctors even know how to treat a patient like me? What if I need surgery? Nothing works for me. Maybe I should just stay home. The fear makes you worry about having a, quote, normal life. Will I be able to work? Should I get married? What about children? Will they get ITP? Will I see them grow up? Will I even be around? Will I be a burden? What if I get a brain bleed? That is our biggest fear as patients. I know that only a small percentage of IT patients get them, but let's face it, we already beat the odds. We've got ITP. Only a small percentage of people get that. And 10 years ago, an MRI showed that I had had a brain bleed. They called it a microbleed. So now I worry when and if it'll happen again. This fear causes you to take extra precautions constantly. You avoid sharp corners. You don't play with sharp objects. You watch where you're walking so you don't trip or fall. You always wear that medical alert necklace or bracelet. You stay away from crowds so you don't get bumped. It robs you of your activities that you want to do. No more biking, roller skating, scuba diving, contact sports, skiing. Even at the gym, I get bruised. Walking and aqua aerobics are the only exercises I can do safely. Guilt. Then there is the guilt about not being able to fulfill your role in life. Will I be able to work? Will I be a good mother and a good wife since I have so many limitations? Will my family be able to handle my disease? Will I be a burden to them? Fatigue. The fatigue is overwhelming, and it limits your ability to do daily chores and activities. My personal mantra is rest to rally. If there is something that I really need to do that's important to me, I need to rest up and not plan anything else so I can rally. Every day of my life is reprioritized depending on my energy levels. My to-do list is constantly changing, and I feel guilty about not getting the things done that I wanted to. And then there is the depression. Did you know 90% of serotonin, your feel-good hormone, is found in your GI tract, where it is distributed by platelets? So, when you have low platelets, less serotonin is distributed. No wonder we suffer from depression. So what does serotonin do? Serotonin affects your gastrointestinal motility. It regulates your moods, appetite, and sleep. It can have a diverse effect on anxiety, temperature, sexual behavior, eating behavior, and movements. It can also affect your cognitive functions, including memory and learning. For us, the ITP patient, not a minute goes by without thinking about how ITP affects our lives. Before I get up in the morning, I stretch. As I get out of bed, I check to see if there's any blood on my pillowcase or on my sheets. Did I cough or spit up any blood? Is my urine smoky colored or are my stools black? Do my gums bleed when I brush my teeth? Do I have any blood blisters in my mouth or on my tongue? When I shower, the water can't be too hot because vasodilation increases bleeding. I scan my body while showering to check for new bruises and petechiae. Sometimes I count my bruises, usually 20 plus. I moisturize because dry skin makes you itch, and itching makes you scratch. And when you scratch, you get petechiae. Should I wear support hose today? Do I need to wear long sleeves to cover my bruises? Or long pants for the same reason? Don't wear anything tight because it can bruise you. Wear shoes that fit snugly and have traction. No heavy handbags because they'll bruise my shoulder. Be careful going down the stairs. Make sure you hold on to that handrail. Should I just stay in bed today? All this, and I haven't even had breakfast yet. That's part of my daily routine. Can you imagine being a parent of a child with ITP? The worries you would have? You'd do anything to protect your child. I know my parents did. You'd also do anything to fix your child and spare them the agony of living with ITP. Adults want to be fixed too, but some of us don't have a way of being fixed. That is where the FDA comes in. You see, you hold the keys to our future. You hold the keys to the treatments that might put us in remission or keep us in remission. We appreciate you giving us the opportunity today to speak. You've heard our stories of life with ITP, and you'll be hearing more. And I assure you that each one of us wants you to remember every word that we've said, and that there are so many more patients out there that are fighting to beat ITP. So many of us hang our hopes on that next treatment, and you can help provide that treatment, that new treatment. We can only pray that more safe treatments are on their way. Thank you.
All right, my turn. So I'm John Phillips, and it is truly an honor to be here. And I hope you all leave with an understanding of my battle with ITP. Before ITP, school was easy, and I was in the best shape of my life. But then I was diagnosed my 17th birthday during my junior year of high school in 2014. And I planned to move on to varsity wrestling and join the military after high school, but with this diagnosis, my world was torn apart. So I'll take you through the symptoms I experienced, what ITP prevented me from doing, how it affected my daily life, how my condition changed over time, and finally, the biggest worries I had about ITP. Now, first, fatigue, depression, and brain fog were horrible symptoms that plagued me every day I had ITP. These symptoms worsened and eventually became unmanageable. Brain fog made it hard to focus and think clearly, and because of this, along with everything else, my grades suffered and school became a struggle. I had to work incredibly hard to fight this haze of confusion and sluggishness that I lived in. And fatigue and depression were an invisible and unbearable weight on me. And my fatigue was so bad that I had to sleep in my car in between my college classes just to make it through the day. I was stuck in a deep, dark pit of misery. And I tried medication, counseling, and meditation, which helped, but none of these things would help enough. So secondly, I plan to try out for varsity wrestling after 8 years of wrestling. but because of the brutal nature of wrestling and my consistently low platelets, I could no longer wrestle. And I was crushed because it seemed like all my hard work was pointless. And I decided to become a manager for the team to kind of stay on, but it wasn't the same. And then soon I started prednisone, and I gained 18 pounds in 1 month, and I had moon face. And my teammates, who I thought were my friends, began to bully me for this weight gain. And so I truly felt ostracized and alone. Sorry, kind of emotional. I also planned to join the military after high school to make my family proud and set me on the right path in life. And I learned that this could never happen for me. So my life and my goals for the future were taken from me by ITP. And I was devastated, because nobody I knew could understand what life was like for me. And I was miserable for the rest of high school and college. ITP ruined many experiences and events for me that were supposed to be fun, because it drained me of my happiness, my ability to enjoy life. I often had to pretend that I was happy to make my family happy and to make things seem okay when they weren't. When I look back, I can say I was never truly happy until after my stomectomy last year. So ITP took a significant toll on my daily life. I struggled just to get out of bed because my fatigue was so bad. And on my best days, I could kind of push ITP to the background, but it was exhausting. And on my worst days, all I could do was just lay in bed all day in darkness, because there was nothing else for me. And then when I had critical platelets, fear had me stuck in a house, and anxiety and stress were always with me. And I hated what my disease had done to my life. So ITP is often described as a roller coaster, because there is no way to know what the next platelet count will be, or if my phlebotomist will dig around in my arm, leaving me bruised and in pain, or if a new medication will work or have terrible side effects. So this uncertainty is frustrating and scary. And when I was first diagnosed, I was in shock. I didn't question what my hematologist suggested. And so this left me with miserable side effects from almost all my treatments, like aseptic meningitis and the weight gain, with no real boost in my platelet count. So I decided to stop punishing myself and stop all my treatments and see how my body would react. And I was able to manage for a while, but my fatigue eventually became unbearable, even when I had higher platelet counts. And this significantly affected my academics and my personal life. I would get panic attacks every time I had my blood drawn because my veins had been butchered so many times. And when I would get home from school, I struggled to get any work done because I just did not have the energy to do anything besides lay in bed. So I was hospitalized with a platelet count of 2 on my 21st birthday, exactly 4 years after my diagnosis of ITP. And it was the same hospital room I was diagnosed in. So this began to seem like just an endless cycle of misery, pain, and losing myself in ITP. And I spent that entire summer either being absolutely miserable on dexamethasone or having a critical platelet count. So I was just tired of life with ITP. And as a last resort, because I did not want to live the rest of my life miserable, I had a splenectomy. But now my count is in the normal range, my fatigue is gone, I'm off my antidepressants, and I can think clearly again. and I feel like I'm finally getting my life back. So now I can talk about my life if my splectomy didn't work or if ITP suddenly comes back. Now, before surgery, I was at rock bottom, and I was very afraid that rock bottom would be my new normal. If I still had ITP, I believe that I would continue to fail and drop my classes until eventually I was forced to drop out of college. I never had enough energy to work even a part-time job. So with ITP robbing me of what it means to be alive, combined with my fatigue and depression, I believe that eventually I would become a shell of myself, a ghost of who I was, just watching life around me but not living it. And so getting my splectomy was a last resort to escape that lifetime of misery that I did not want. And life without a spleen leaves me at greater risk of infections, but it is worth it to be just free from this life-draining disease. And I am still dealing with the trauma and negative thinking I've developed because of ITP. In conclusion, ITP was a life-changing diagnosis. It left me with many scars, both visible and invisible. Thank you.
My name is Luigi Duremo. I'm originally from Ottawa, Ontario, Canada, but I now live in London, Ontario.
I'm Jennifer Duremo, and I'm originally from Toronto, Ontario, and I've been living in London, Ontario for the last 16 years. I'm Luca Duremo's mom and Matteo Duremo's mom.
Luca is a very handsome boy who was fun-loving, compassionate, and fiercely loyal to his friends and family. He was diagnosed with ITP when he was around 7 years old. We initially noticed a fair bit of petechiae on him, and we were extremely concerned with what we had seen, so we brought him to emergency. And at the ER, they initially were suspecting or had some concerns about child abuse. They were expressing some concerns, some questions about that type of thing. Subsequently to that, they had actually completed some blood work and found out that his blood platelet levels were 27,000, and that was extremely low. With levels so low, we had to modify his daily activities, his recess activities, not to go on to climbers. We modified his soccer schedule to protect him, to keep him safe. And in that first year, he was not a bleeder. He had only the petechiae, but never had a nosebleed or never had any type of bleeds of any sort. So after consultation with the hematologist, we determined that they were going to do a watch and see approach. And we would just monitor him and advise them whenever we saw anything out of the ordinary for him.
Within the first year after Luca was diagnosed, his platelets didn't really fluctuate a whole lot, but they did fluctuate somewhat. So they ranged somewhere between below 10 to around 40K. So he did have a little bit of movement, but regardless of the level, he didn't have any bleeding episodes other than just the bruising and petechia. And in the second year, it was more spontaneous. So even if he didn't bump into a wall or something, he would still wake up with bruises and some petechia. But the third year is when things really changed for him. His levels were almost always below 10, so we didn't see that fluctuation anymore. And I would say within the middle, well, in October of 2017, he started to get a lot of nosebleeds at school, and I would say they were happening quite frequently, so his teachers were concerned. And then by the first week in November, he had this epic nosebleed one night, and it was so bad that he had swallowed a lot of blood, so he was throwing up a lot of blood. We weren't able to control the nosebleed ourselves. He had these clots that would fall out of his nose that resembled worms. And after a while, we took him to the ER, and they ended up stopping his nosebleed and then sending us home with some prednisone. When they sent us home with prednisone, we thought that would work, but after a week, we had learned that his levels didn't budge at all. And then he had another really bad nosebleed. So after that second nosebleed, around the end of November, we decided to try the IVIG. And so he was hospitalized for that and had a really bad reaction after that. We were warned that he could have a bad headache, but what he ended up having was something that was worse than a headache. It was more a migraine that hurt all over his head. He literally sat on our couch in the same position. He couldn't move. We tried to lie him down, and it was too painful for him. And we had to turn off all the lights because the light was bothering his eyes. He was throwing up a lot, so we were concerned that the Tylenol really wasn't doing anything for him. And it was a really scary evening for us because we sat there and just watched him suffer. He was not able to speak, so he couldn't really get any words out. He was still talking in himself through the night, but he was starting to get a little out of it, but we just attributed that to his lack of appetite. He hadn't really eaten 2 meals up until that point. And then by the afternoon that day, Luigi went to speak with him, and he was slurring his words. So he was taken to the hospital, and by the time he got there, he had a lot of pressure on his brain, so they were really worried about that. And he ended up having a craniectomy, and he did quite well after that. So they had talked about how he had his left pupil by that time was fixed, and the neurosurgeon came out and talked with us and said normally that's a really bad sign, but after the surgery the pressure was reduced. They felt that they had a handle on it, and his left pupil became unfixed. So she said she was really she had some hope, and had prepared us for potential personality changes within him, but that, you know, he was going to make it. That was the impression we had. And then throughout that night, things changed, and he ended up having a second bleed, we think, and he ended up requiring another craniectomy, and after that, he wasn't responsive at all. So he was on life support for a couple of days, so we had a chance to be with him, and ultimately the life support was discontinued on the 15th of May. So he was 10 years and 3 months, and it was very hard for us, and still is.
We wanted to share our story to the community at large because we want to raise the awareness. We want to create this environment, an opportunity for discussion, and perhaps change or influence protocols, guidelines, so that another family doesn't have to go through this event.
I'm happy that I have a house and a family and a home, and I'm happy I have food and toys, and I'm happy I have a home. I'm happy I have a mom and dad and a brother.
I know that video is heartbreaking to watch. Luca's mom, Jennifer, wanted to be here in person to share Luca's story with all of you. That's how strongly she and Luigi felt about it. And the reason she's not here is because she had a baby last week, unexpected. A little boy named Oliver Luca Matteo. Oliver or olives, I should say, were Luca's favorite food. So Oliver and Luca after his big brother, and Matteo after their middle boy. You know, while it might be upsetting to hear stories like Luca's, although it's rare, it is a reality. And at PDSA, we hear from family members who've lost a loved one to ITP, I'd say at least 8 to 10 times a year. So that's why it's so important to find a cure or additional treatments for patients who are unresponsive to treatment. So thank you for your attention, and let's give the entire panel here another round of applause. As I said, it takes a lot of courage to share such personal aspects of your life, and that is exactly the type of information that we need all of you to share with us today. So I'll let our panelists go sit down if you want to participate in our second set of polling questions on the topic of symptoms and burden of ITP. So once again, please pull out your phones, your laptops or your tablets, and we want to remind you that we are asking just one person per family to respond. So whomever that designated respondee is, if it's the patient or caregiver on behalf of the patient. And again, if you are still having an issue logging in, raise your hand, and we have a few people in the room who can come over and help you. So the first question, which symptoms from ITP has the most significant impact on your life? And we're just asking you to select the top 3. So I think not surprising, fatigue has the biggest impact, I think followed by anxiety. And what's interesting about that is Dr. Bussell mentioned the I Wish survey that PDSA was also a part of, and it looked at both patient perception of the burden of disease and physician perception of burden of disease. And while fatigue is the biggest symptom or burden of disease for patients, physicians think it's bleeding. For them, they think fatigue is like 3 or 4 on the list. All right, moving on to the next question. What activities does your ITP limit or prevent you from doing? So sports are the capacity to exercise, followed by hobbies or social activities, kind of tied with traveling or spending time away from my family. But obviously it has a big impact on many things in your daily life. All right, moving on to the next question. How has your condition changed over time? So around 30% of you are saying it's controlled with medication. And it's nice to see we do have some folks in the room or online who are currently in remission. But obviously for other folks, it varies a lot. All right, moving on to the next question. What aspects of your condition cause you the greatest anxiety? And please select the top 3. So obviously the energy levels and the effects on my mental health correlate with fatigue and anxiety, but it's interesting to see that fear of the unknown, which we don't really talk about a lot and which all of our panelists talked about, actually has a huge impact or causes you the greatest anxiety. So now we would like to open it up to the floor, to everyone to share their own experiences on the symptoms of ITP, the impact those symptoms have had on your daily lives, how that has changed over time, how that might vary from day to day. And we have 2 microphone runners in the room. We have Alexandra over on this side of the room, and we have Jared over on this side of the room. Again, please raise your hand. They'll come to you with a microphone. I'd like you to state your name. You don't have to state your last name, but just state your name. If you'd like to share with us how long you've been living with ITP, or if you're a parent of a child, how long your child has had ITP, because we want to make sure that everyone in the room can hear you, and we're also recording this. We have a set of questions that we would like to follow. So we're going to start out by talking about the top symptoms that impact your life. So question number 1, of all of the symptoms or disease manifestations that you experience because of your condition, which 1 to 3 symptoms have the most significant impact on your life? And again, is it fatigue? Is it bleeding? What kind of bleeding? Is it anxiety? Is it depression? So don't be shy. Anybody in the room like to share their ITP story or contribute to the conversation? I know once we get 1 or 2 of you talking, then everybody else will start opening up. I was going to say, I don't want to start singling people out, because I know most of your names, and I will have to do that.
I would say that just the limitation of the physical activity. I have 3 sons, and so when we go on vacation, they want to go whitewater rafting or skiing or bicycling or whatever, and many times I'm sitting by myself while they're out with my husband doing these activities. So that's very limiting and frustrating.
And how long, can I ask you a question? How
Yes.
long have you had ITP?
12 years.
And is your ITP being controlled right now? Are you on
Yes.
medication?
Yes.
But obviously it's still an issue, and it has a big impact on your daily
Right.
life.
Yes, I live with platelet counts anywhere from 10 to 20,000.
Do you suffer with the fatigue?
Yes, probably not as much as I am hearing other people. I've always been a very active person, and so I kind of push my way through it and don't try not to think about it. But yeah, I do find that if I push myself too much, that it's very debilitating.
Well, thank you for being the first one and sharing your story with us. Anybody else? I mean, we'd love to hear from the caregivers as well, meaning the spouses, if you'd like to talk about how ITP has impacted your life or your family life. So I think we have somebody over here.
I would say that, my name is Lexi Latimer. I'm 12 years old. And I would say some of, the biggest, hardest things for me is not being able to do things with my friends. I get invited to, a lot of things that I can't do. My neighbor, she has a horse. I can't do that anymore. I can't ride the horse. I can't do a lot of activities in sports. I did dance. Well, I'm starting back at dance, very little by little. But I can't do, any cheerleading or volleyball like I used to. So that and, fatigue, I would say. I'm always tired, which makes it really hard for me to, do schoolwork and stuff. So, yeah, I would say those are probably the hardest things.
And Lexi, how long have you had ITP?
I was diagnosed last October.
And is this your mom here?
Yes.
And could we, Mom, don't be shy. Lexi got up here and she spoke into the microphone. How has, from your perspective, how has ITP changed your daughter's life and your family's life?
Just trying to wrap our head around everything. Whew, this is hard. Just trying to wrap our head around everything and adjusting to having to say no. And there's so much that she misses out on now. And just trying to adjust and figure it all out. We're still kind of in the beginning stages of it, so having to tell her no, I think, is the hardest thing, because she doesn't understand, and it's still hard for us to even understand. And the kids are going to Six Flags and riding roller coasters and riding the horse and riding the four-wheeler and jumping on trampolines, and having to say no is just the hardest thing.
Well, thank you for sharing that with us.
Thank you.
Yeah, and Lexi, if you get a chance, I hope you, because you're kind of like the borderline. I don't know if you want to go into the kids camp or the teen session, but there are, of course, other children here with ITP. I think who've been where you've been, and they've made a lot of great friendships here at our conference each year. So I hope you get an opportunity to meet those other kids. But thank you for sharing your story. Anybody else? Come on, a 12-year-old got up. Somebody else want to share their story? In the back.
Hi, my name is Allison. I was diagnosed in October like she was. And I had been a cook for the Head Start program for 18 years. And because of my ITP, I can't, play around with knives, of course, and different things in the kitchen. So now the fatigue is really bad. But I still work every day, but I'm on paperwork now. But mostly the fatigue for me is the biggest thing, because I'm used to doing pretty much everything, and I have children and grandchildren, and I'm just really a busy person, but my platelets go to zero almost every other month. I spent most of October in the hospital because it was at zero and I was at work. And my doctor called me after blood work and told me to go straight to the emergency room. So that's pretty much what I've been dealing with. I went to the doctor this past week before the conference, and they're down to 11, but my doctor still let me come.
Well, thank you for sharing your story as well. The next question that we have, or do we have somebody else that wanted to make a comment? Oh, okay, one person over here. Hi, Wendy.
Hi. Hi. I feel a bit more comfortable sitting down, if that's okay. I'm from New Zealand, and a few of you, I've met many of you before. Our story is that my daughter, Azaria, was 2.5 when they found she had a platelet count of 19, and she had bruises, massive ones all down her spine and massive ones on her cheek and everywhere. So, of course, it was suspected about child abuse as well. But once they did the platelets, that was fine. But they also thought she might have leukemia, so she's had bone marrow biopsies and all sorts of things because she had pain in her body that was not explained. She was having a lot of bleeds, so because she was 2.5, she would fall over and hurt herself a lot, and she'd get too tired. I'd have to carry her everywhere, but she would fall over and she would hit her head or her body. We were trying to stop her, but 2-year-olds, they do things like that. So we've had times where she's been unconscious. She's had wiped her eye and had blood. She's had blood in her urine coming out of her mouth. Like one of her worst bleeds, we couldn't get it to stop, and she was coming out of her mouth and nose for an hour and a half. Because of her ITP, we actually moved to be close to the hospital because we were going so often to the hospital with her. And when she was diagnosed, I had 1-year-old twins, and I needed to leave my babies at home because they were really close in age. So anyway, I'd be going. My husband worked in the city, and we I'd be commuting back and forth. So we actually moved. So it seems a bit counterintuitive, but we moved to an island off the coast of Auckland, a small island, because they helicopter her in an emergency to hospital, which means the ambulance takes 10 minutes, and then if she needs to, she'll be on the roof of the top children's hospital in 10 minutes, which is why we moved. And her last time she had a fall. Thankfully, she's been better the last 1.5 years, but the last time she had a fall, a bad one, was she was winded. She had petechial eye all on her, and she was having trouble breathing because she fell out. She fell out of a tree, and she had blood coming out of her mouth and urine, and she had a headache, and she was winded, so she got airlifted to hospital in a helicopter. One thing was that when she started school, she was at school for 18 months, but she was having bleeds in class and in the library and everything, and so she loved school, but then she was getting so much anxiety about it and fatigue that she stopped wanting to go to school. So I took her out of school and homeschooled her, my 3 kids, for a year. The other impact, so she's back at school now, and she's been better, but yeah, it's affected so many areas of our life. Like one of the things with my family, one of the worst things actually at the moment, even though my daughter's been better, is that we have family that don't support us. And like my sister, who lived near the hospital, never came to support me. Even when I had to go to the oncologist, I had to go on my own hundreds of times, and my sister would not come. So that's really made it hard for us. And the other thing is that, which I want to share with you because it's actually real, is that other people don't believe that she's sick, even though she has the bruising, the petechiae. And in December this year, so she's had ITP for 6 years, my husband found an email from his mother telling other people that I actually have Munchausen's by proxy, which means that I'm abusing my child and causing her to have a bleeding disorder. She actually says that I'm faking and that I'm making it up and I'm doing it for attention. And why I want to share with you is because people don't really understand. She was a nurse, my mother-in-law, and I've been with my husband for 16 years, and she's been telling people for over 5 years, including his family, they all don't believe that Azaria's sick. And what that's done to me is that I've been reliving to justify all the times she went to hospital. In my head, reliving, going through what it's like and what we had to go through and justifying why. Because every time she went was, you know, the ambulance comes, they assess it wasn't my decision. And then I think coming here just reminding me of what we've been through with her and the fact. So right now, I have not been able to speak to my mother-in-law, and I never want to see her again, and I can't. It's ruined our whole life. It's really hard for our family because I haven't been able to go to our family weddings or my husband's cousin's wedding or anything, and my husband's now having to defend us because yet she's telling everybody that I'm crazy. My daughter's not actually sick.
Well,
so, yeah, sorry.
No.
But
I think you bring up a lot of really important points, things that maybe most of us don't think about, or people from the outside don't think about. I mean, how many of us in this room have heard, well, you know, but you look fine, you know, it doesn't look like there's anything wrong with you. You know, I know when I was in the throes of my ITP, And I was hospitalized numerous times, and my husband, his company had a company affair, and I was so tired I couldn't go to it. And there were a couple people talking about me. Somebody else overheard it, and they said, well, what's wrong with Ken's wife? And they said, oh, nothing, she's just tired. People just don't understand. I mean, this is obviously the extreme with what Wendy's going through with her family, but it just goes to show you the type of impact ITP can have on your life in so many ways. The fact that your husband had to get a different job, you had to move to a different location, and now you're having all of these family issues. So thank you for your courage to share those stories with all of us. Another comment there. And question number 2, we'll just get through these questions, but obviously everybody's just sharing their story. If there are any specific activities that are important to you but that you can't do anymore as fully as you would like because of your condition, the examples of different activities or even engagement in personal relationships, participation in sports, completion of school or other activities. So we have this lovely lady over here in the orange.
Thanks. My name is Allison. I just wanted to talk about the bleeding and the stress that it causes, whether you are or you're not. And for me, simple things like going to the dentist and where there could be bleeding. And so you have to get your platelets drawn before you can have the dental work, and then making the appointments and having to disappoint, the dentist. Are you going to be able to show up and have the stupid procedure? So it makes you feel like you're not accountable for, you can't even make an appointment without having all of these check things in place. And then just like the dentist is a simple one, but, bigger ones like I have postmenopausal bleeding. And the other day I had a random routine blood check and my platelets were up. They were 98. So I have a procedure that I've been not getting done because I don't want to go through all of the things to get my platelets up high enough. And then I have an example, and I have to see the oncology doctor to get it done. Anyway, they say, oh no, we can't fit you in for that procedure on the spur of the moment. And they want me to schedule, and they want me to take all of these drugs to get my platelets up, but then the random day that they are elevated, it's like, why don't I fit into the criteria to be fit in? What? It just feels like you're between a rock and a hard place. And so I think I heard somebody mention or, talk about with our platelet numbers and how much we focus on them. And it would help if there were ways we could test our platelets independently without having to go to the, you know what I mean? Like diabetics can check their numbers. It would help a lot for us. And then we don't have to always be, So it causes anxiety, right? Because you're waiting for the result, and then the whole time you're waiting to get the answer. Am I going to get the test today? And then you can't even think about the anxiety for what you're having the procedure done because you're just worried, can I even get there? Yeah. So I just wanted to talk about that for the FDA and the people helping, because that affects me the most every day. It's like the fatigue, yes, but it's the anxiety of just regular life problems that we have, going to the dentist or going to the dermatologist and they take out their equipment to fix something, but wait, I don't know what my platelets are. I'll have to come back, So
you're right. I mean, and oftentimes preventative procedures so that we don't get other things like cancer, colonoscopy,
and then you're
mammogram, dermatologist.
Yeah, and you're weighing the risk. Well, what's the risk of a cancer when I could bleed during the procedure? And, like a polyp, like a colonoscopy, everybody at age 50, you got to get that. But I have to go into the hospital to have that procedure. And how many platelets? What happens when they're taking the polyps and I start bleeding? Are they gonna is it gonna work, If they give me platelets, will I have a reaction to the platelets? Just layers and layers and layers of worries on just basic daily things, And so for me, the postmenopausal bleeding, I just wanted to throw that one back out because, what is that? Is my platelets low? And yeah, so thank you.
Well, and you can also hear more about that in our Women and Girls session on Saturday afternoon with Dr. Michelle Lambert. I think she's somewhere in the room. And then speaking of, developing some type of at-home platelet counter, Logan, who's here with us, who will be on the patient panel in the afternoon. He's one of our teens, and he's been an ambassador for us for many years. He has lots of ideas about developing an at-home platelet device. So if we have any engineers in the room or any of our pharma companies that might want to support Logan in that effort, I think everybody here would be really happy. So question 3, I think we're obviously answering a lot of these questions. How do your symptoms and their negative impacts affect your daily life on the best days, on the worst days? Anybody else like to share their story? Oh.
My name is Rebecca, and I'm actually speaking as a caregiver for my husband, John. And I know that in the last 5 years, I have seen him have what I would never be able to handle for some of his days that he has. Because of his ITP, he had an infection and he had to get a colostomy bag. And if you're not aware of what that is, it's basically a bag that catches your poop. And he has had accidents in public places. And I'm sorry to tell all your business, but we've had no physical relationship for 5 years because his ITP has taken everything out of him. I work, and he tries very hard to take care of the house while I'm at work. And some days all he can do is rest. And it's very hard to see what, at one point, he was so happy, and now he's just not the same. And he's had to live with this for 3 years, and that's been very hard for him to have people helping him change his bag and cleaning up after him and help him with his showering. And that's all I wanted to say.
No.
Sorry about sharing your business, honey.
No, thank you. Thank you, John. Again, ITP, it's more than just a bleeding disorder, isn't it? It really has an impact on so many aspects of a person's life and on a family's life. Do we have anybody else that would like to share their story? Oh, we've got somebody in the back. Oh, hi, Madonna.
Hi. I'm so grateful for the opportunity to be here, and I think that's shared by everybody today, that this conference means so much to us because of our ability to speak to people outside of this room about what we're facing and have faced. I was diagnosed 38 years ago, and I've said this publicly before, it was on my birthday, so every year means another year of survivorship, and I'm very grateful for that. I would think that some of the ways I could best answer the 3 discussion questions are to say that some of the feelings we might have towards our existence and our illness are so deeply felt that sometimes we can't really express it the best way possible. But I took a couple of little notes, and I feel that sometimes it's anger, and I don't think that's been talked about today, and specifically that word, but the anger you get, in my case, when you're diagnosed not just with ITP, but something else, and something else, and something else. In my case, it was lupus, and then thyroid, and many of us in this room and other ITP patients also face other autoimmune diseases, so I wanted to throw that out today. And the other thing, too, is one of the things I've learned so much from my involvement with PDSA is that this is really a snowflake disease. We're all different, but coming together like this is very good for all of us. And finally, on the last question, the symptoms and their negative impacts affect your daily life on the best days or the worst days, on the worst days. I'm past the point where I worry about the number, and that, like I said, 38 years of diagnosis is really a very long time, and I'm very grateful. But there's always that feeling in the back of your head, it could come back, it could get worse. And not to dwell on that, really, truly not to dwell on it, but you can never really escape the idea that the next blood test could be it. And I did have 2.5 years under 20,000, so I was critical at that time. And I just, I don't know, chug along now with 42, 43,000 platelets. And I stay busy. It's what helps me. And finally, one thing has not been discussed at all today, and that's the impact it could have on a person financially. I think we need to talk about that at some point in another day.
No. Well, no, we could talk about it right now.
Well, it does. If you find that
it's important.
It's important. If you find, like myself, you're not working full-time anymore, can't work full-time, or the things that you have done in your previous professional life might be so difficult to achieve now. Many of us don't work to the age that we thought we would be working, to a full retirement age. And so the financial aspects of this have been difficult. Nobody prepares you for this. I never was prepared to even know what a platelet was, much less that it would be an important part of my life. My lupus doctor tells me that low platelets are tied into that syndrome as well. So there's some information you can get, but some things you just have to experience. And I'm so glad today that we're able to talk to everyone in this room and the people are listening. And I thank you again.
Well, thank you, Madonna, for sharing your story. We do have somebody up front here. I just wanted to mention, some of you in the room know that I was diagnosed with an immune deficiency 7 years ago, so now I get treated for that. So my ITP then ended up being secondary, so of course I should have never had a splenectomy. But, having the immune deficiency, lifelong, having treatment, it really pales in comparison to the ITP. And I always say that if my ITP wasn't in remission, I wouldn't be able to do what I do. I wouldn't be able to run the PDSA. So I'm very grateful for that. And I do understand how it can change your daily life and your career aspirations as well. Where are we at? Oh, right here.
Hi, I'm Mieke from the Netherlands. I have ITP for 11 years now. I'm on end plate, and my count is about 50,000, so you say here in America. I inject myself, by the way. I've sometimes felt sorry for myself because of the fatigue, but when I hear your stories, I think I'm lucky. I don't have a lot of issues, except the fact, the fatigue. And I had made a decision a couple of months ago to work less hours because it was too much. So I work now for 22 hours a week, and that's more than enough for me. It was hard to concentrate, and so that was a thing. But on the other hand, I can do a lot. I travel a lot. I don't do actually sports, but I try sometimes. But well, I play tennis, okay, but that's it. But it does affect my life, but I think not as much as the stories I hear from you all. So I guess I can call myself lucky. Yeah, I don't know.
Wow.
So,
Thank you for sharing that. And again, I remember when I was diagnosed, I thought I had the worst case of ITP ever. And then I met so many of you, and I realized, you know what? I don't have the worst case of ITP ever.
That's exactly how I feel right now. Yes.
I think a lot of people feel that way.
Yeah.
But I think that the important part of being here today too is hearing all of these other stories, and just like when I first heard Joan Young's story, it gave me a tremendous amount of hope that I can get better, and I hope many of you in this room leave this conference on Sunday feeling the same way. So we have about 7 more minutes before lunch is ready. Anybody else like to share a story or any comments? Where's the microphone? I don't know where the microphone is at. Sorry, I can't see. Oh, okay, I'm sorry. Jenny Krieger.
Hi, my name is Jenny Krieger. I am Kaden Krieger's mom. And Kaden was diagnosed when he was 6. That took him away from wrestling and football. He gets IVIG usually every 3 months, and that usually keeps him stable for 3 months, and then he drops. I just want to ask the FDA, please, please approve these medications for children. Nothing is approved for children. Children's lives matter too. Thank you. And thank you, PDSA.
I saw a couple other hands go up. Oh, Jared?
Oh, actually, I've had chronic ITP for 9 years, but I refuse absolutely to let it get the better of me. I've had bleeding, I've been in hospital, and I have a lot of stories to tell, but I want to tell you that you can overcome it, and one way is just to just say, okay, I'm going to do this, whatever it takes. So try and overcome it, and think of your blessings. Think of poor people in other countries, what's happening to them. And anyway, I just want to say that I just refuse to let it get the better of me. That's what I got to say.
I think in general, ITP patients have really positive attitudes or try to make it look like everything looks good on the outside. And maybe that is one of the problems, when people see us and they think, oh, you look great, you're happy, everything's fine. And so, Pat, thanks for sharing that. But again, it does have a huge impact on a person's quality of life. And so, that's what we definitely want to hear today.
Hi, I'm Al. I'm coming up on my 5-year anniversary. So, I've had all the symptoms, the fatigue and the depression, and that's sort of like the new normal, and the anxiety and the social isolation and stuff. The one aspect I also wanted to add, maybe of interest for FDA and others, is it's mentally exhausting to manage this thing. It's just like your hematologist does the best he can, but he's an oncologist too, and maybe he has 3 other ITP patients, and they're scattered the experts are scattered all over the country, so it's not really practical to just go relocate to where they are. And so you kind of have to manage it yourself, and it's just exhausting. It's like you have to keep up with the research, and you gotta be on the message boards, and you see a new symptom, and you're like, okay, what do I do now? And a med will work for a while, and then it doesn't. And then, that's just exhausting mentally and physically. It occupies your brain every day when you wake up, and you can't do other stuff because that's occupying your brain. And so anyway, I just want to add that it's like Dr. Bussell said, it's a complicated disease. There are no answers. They don't necessarily know what works for one person doesn't work for someone else. So,
well, and that mental aspect is on top of the fatigue and anxiety and depression that you're already dealing with because of the disease, right? Anybody else? Oh, with somebody in the back? See, I told you, once we get you warmed up, we won't be able to stop you from talking, which is all good.
Hi, my name is Karen, and from 2010 until this last December, I was watch and wait, and from December to April, platelet count was between 10 and 20,000. I started a medication. My concern is costs. I'm retired, I'm on Medicare, and there are very strict rules about what it is going to cost. And that was really a huge surprise. And since I'm retired, it's a big worry about the bite it's taking about my future financially.
Well, some of the ITP drug manufacturers do have patient assistance programs, and so, of course, our exhibitors are here today, so I encourage you to go talk with them and ask them that question. And then in addition to that, on Sunday, we're going to have a program. It's basically a Washington update, although I don't know how much we really know at this point in time, what's going to happen with the Affordable Care Act. But we'll get an update on what's happening and access to ITP treatments. So I think we have time for 2 questions before we go to lunch. And Karen?
Hi, my name is Karen. I'm from the Netherlands. I will leave my ITP story for what it is. I have ITP myself, but you triggered me what you said about that your hematologist is only seeing 2 or 3 patients. And what's going on in the Netherlands, and we are a small country compared to you, but they are setting up expertise centers that all ITP patients can go to one specific center for ITP treatments. I don't know if that's going on in the USA, but I thought. worthwhile to mention.
Karen, establishing centers of excellence is a long-term goal of PDSAs. But we do have a ITP expert referral list at the office. So if you would like to, you can call the office, you can email the office, and depending on where you live, obviously we have a list based on geographic location, not only in the U.S. but in Canada and internationally. So we have compiled this great list of ITP experts. So please feel free to contact us if you're looking for a new physician, or even if you want to go see someone for a second opinion. And of course, our medical advisory board, I mean, they are, world-renowned experts, and you might think to yourself, well, I'd never be able to get into him or to her. That is not true. They are so fantastic, and there have been numerous times over the years where I've contacted somebody, even just for an email consult, and responded right away. I'll never forget, on Thanksgiving, I emailed Dr. Cooter, and he responded to me within an hour, and he contacted the patient on Thanksgiving. I mean, that's true dedication to our ITP patient community. So did we have just one more, or no? Yep. Jared, did we have one more person, or no? Okay, we're done. Well, Lib, you're on the second patient panel, but would you like to, you can be the last person. Have the last word here before we go to lunch. Yep, she's bringing you the mic right now.
I live in a very rural area of Virginia. My name is Lib Elder. I've had ITP probably my whole life, diagnosed for 32 years. And I live in a very rural area of Virginia. I am not just my doctor's only ITP patient. I'm the only ITP patient in the county or the nearest city. And in spite of the fact that I've had this disease for 32 years, he will not listen to my experience. When he says, let's do this, and I say, I've done that 17 times, and this is what happens, he doesn't care. I either do what he says, or the last doctor fired me as a patient, because how could I possibly know anything about a disease that I've had more than half my life that he doesn't know when he hasn't even been a doctor that long? And it's really, really maddening.
All right, well, that's a good way to end. Well, thank all of you for sharing your stories and experiences with us for living with ITP. So this concludes our morning session on topic 1 on the burdens and impacts of ITP. After lunch, you'll have an opportunity to discuss how you manage your ITP and the treatments and side effects. And now we're going to have lunch in the Kennedy Ballroom. So we'll see you back here in, I think, like 45 minutes. Thank you.